morning, everyone. I have the pleasure of introducing Dr. Pender today for Internal Medicine Grand Rounds. He comes to us today as an assistant professor in the Department of Laparoscopy and Bariatric Surgery in the Department of Surgery. He actually did his surgical residency training here at East Carolina University and his fellowship in minimally invasive and bariatric surgery here. And he comes today to talk to us about a very relevant topic that happens to be the original article as well in the New England Journal of Medicine this week about obese and metabolic syndrome patients and surgical treatment. So he's here to kind of help us figure out how to make our better referrals, probably not be an inpatient consult, but how to learn how to better treat these patients. So please welcome Dr. Pender.
Thank you. Thank you all for having me. Dr. Dar wanted to do a two-part series on weight loss surgery, and so I'm the lead in talking about the nuts and bolts of what it is, who should have it, and a little bit about how it works. And then Dr. Dar next month is going to get more into the basic science of GLP-1 and insulin levels and that sort of thing. But I think it's a good timing, as Alexa was talking about, with the New England Journal of Medicine articles, which we've been waiting for about 10 years now at ECU, having published that first article. Actually, 10 years ago, Dr. Pori speaking about diabetes maybe being a surgical managed disease. So we're going to talk about the common types of weight loss surgery and kind of try to dispel some of the myths about is it safe and what is the best surgery. I want to talk about the criteria, who should be referred and who needs it. A lot of times it's not as obvious as you think. And also, how do you take care of these patients? A lot of times we'll get calls from patients, medical homes, inpatient questions. This is becoming one of the most popular performed operations. We as a hospital, we perform about 15 of these a week. So you can imagine, having done these here at this institution for going on 20 years, that the chance of you running into a patient that's had a gastric bypass is going to be pretty good. And there's some things that you need to be aware of. So I'm going to try to dispel some of the myths. It doesn't work, it's too dangerous, they'll gain the weight back. These are some of the things that people in my clinic, when I'm presenting them with weight loss surgery, that they say, well, I heard, my aunt had it and she gained back her weight, or so-and-so had it down in Morehead City and they died. And a lot of the things about that you can't eat or can't do this, it's a force in a different lifestyle. And then the bottom question is always, the fat people just need to exercise and eat right, and they'll lose their weight, just like they do on TV with The Biggest Loser. So just some nuts and bolts data. World Health Organization, globally 44% of diabetes, 23% of ischemic heart disease, and 40% of certain cancers are attributed to overweight and obesity. The scary thing is that this rate of obesity is doubling since 1980, and there's no longer, one obese child in the class in an elementary school. It's starting to be half of the class in the elementary school. And what I'm dealing with is really adult onset obesity. And the scary thing for me is looking at my child's school and seeing all the obese children. And that's going to present a whole different problem. Instead of people developing diabetes in their 20s or 30s, or a woman has a baby, can't lose the weight after the birth, and then spirals down into obesity, and then develops diabetes. You're going to have people developing diabetes at a very early age. Bone structure is going to change. I mean, when I do a gastric bypass on a patient, they turn back into the person they were when they were 20. Well, if you've never been that person, it creates an unusual problem for the way people will look and their overall health. 1.5 billion overweight people in the world. So there's 1 billion smokers. Okay, so think about the health disease associated with tobacco use. Think about the health diseases associated with morbid obesity. So surgical options. You've heard about the band, the bypass, the sleeve. I want to go into the anatomy briefly and tell you some of the differences in those. The Greenville obesity procedure, or GOP as we call it here, that term was coined by Dr. Porres back in the 80s. Dr. Porres, MCV, and in Indiana, they got together and started describing an operation for weight loss surgery. So it really was pioneered here. And the way he described his procedure, he just described it as a Greenville obesity procedure, and that's how GOP got started. We reduce the stomach volume to 2 ounces, and we create a malabsorptive limb. So we go down to the ligament of Treitz, we measure down about 60 centimeters, we divide the intestines, and the distal end we bring up to this pouch that we've created. And that creates this type of anatomy. So the stomach remnant, which is this part right here, remains, and this is called the pouch. It's a remnant pouch. Then the alimentary limb, no digestive juices in here at all. So you need food, digestive juices, and intestinal lining to create absorption. So you only have food and intestinal lining here, and you only have digestive juices. So you get a malabsorptive picture. So it's not just purely restrictive. Instead of eating a chicken breast, you can only eat a chicken wing. And that chicken wing, as it moves its way down here, doesn't get absorbed like it does now prior to surgery. Resolution of comorbidities, within 9 months, you're going to see 85% of type 2 diabetics go into remission or have glycemic improvement. Hypertension, 50% improvement. Usually what I see is, instead of being on 50 of metoprolol and lisinopril, we'll get them down to just being on lisinopril, 25, and sometimes get off of it altogether. Obstructive sleep apnea is huge. I mean, I think that's one of the most underdiagnosed problems we're faced with as physicians, especially in the operating room. A patient with obstructive sleep apnea is at very increased risk of a sudden death after surgery because of all the anesthetics and narcotics. And the hospital and anesthesiologists are now wanting these patients to stay overnight for outpatient surgery. So that's going to create a huge a logistical problem for where to put all these patients, because it's very underdiagnosed. But within 3 months, patients need to have another sleep study to see if they need to have their settings reduced or to do away with the CPAP machine altogether. Asthma, a lot of the pulmonologists who come to our research meetings on Tuesday looking into the inflammatory process that's going on in obesity. Is that related to the reactive airway disease? Because we do see improvement in asthma after losing weight. Gastroesophageal reflux disease, obviously, if you staple across the stomach and the acid's produced in the antrum, it can't get back up into the esophagus. Weight-bearing arthropathy, I think 98% of my patients have this problem. Probably 50% of my referrals come from orthopedic surgeons. Someone refers the patient to orthopedics to have joint replacement therapy because every time they come to see him, the patient's complaining of joint pain. They send to the orthopedic surgeon. Orthopedic surgeon says, go see Pender, get your bypass and come back and see me. Infertility, polycystic ovarian syndrome, amount of estrogen that's produced by 100 pounds of extra fat makes infertility. Several patients have come to see me purely for this reason, and that's probably one of the most satisfying operations to do, because they really don't care about what they look. They're usually pretty healthy, and when they come back a year later with a new baby, it's very rewarding. Cancer, we're seeing a lot of this in the news about estrogen sensitive cancers. Pseudotumor cerebri is a very rare condition, but if they're obese, this is really one of the best things for it. The gastric band, this has brought just a huge spike in the number of referrals and patients coming to see us because of the early. Let me backtrack. So when Dr. Porres and MCV in Indiana first started describing this procedure, it was very new, was dangerous. But when Dr. Voorhees published that article about 12 years ago about diabetes going away within the week after gastric bypass surgery, insurance companies realized the cost savings that this would bring their companies. So they started paying for it. And when they started paying for it, a lot of surgeons started trying to do it. And a lot of people suffered from that learning curve. And that's where you had all the catastrophic problems with weight loss surgery. Dr. Voorhees, feeling, I think, partly responsible for started a program called the Surgical Review Corporation, where you had to actually become a Centers of Excellence. You had to get your program inspected. You had to demonstrate morbidity and mortality rates that were acceptable. And with that, we've made it a very safe operation. I'm going to get to that later. But what happens is the general public was terrified of the operation. So when the idea of you just come in, you get a rubber belt put around your stomach, and you lose as much weight as a gastric bypass came out, the population jumped at it, just like they do, Buns of Steel and Thighmaster and all the other trendy things. So it does work for some people, but in Europe, 10 years ago, they were doing the band, and they were like, "You're crazy, Americans, doing these gastric bypasses. You need to do the band." And now at our national meetings, the Europeans are coming, going, "You're crazy to be doing that band. We're all doing bypasses now." So we're seeing a lot of the. There's probably too many people getting bands, and there's probably a certain population that needs the band and not the bypass. So there's no malabsorption. It's basically your patients whose weight has done this their whole life. They're able to lose it, but they can't keep it off. And what it does is that it's like a ratcheted instrument. You have to put the effort in to turn the bolt, but once you turn it, it's not going back. But you have to do all the effort, and that's a big difference between a bypass, which you can take a couch potato and perform the operation on it, and they're going to lose weight. But a band, they have to exercise. They have to choose the right foods because it's only solid calories. And think about the most dense calorie foods out there. They're all liquids. You can go to Andy's and get a milkshake and chase it down with an orangeade with a band. Okay, so you can get cookie dough and microwave it and drink it. Yeah, we've had patients do that. So we have no control over that. So a well-motivated patient who has, and this is big for North Carolina, who has the resources to go to a gym, get a trainer, and exercise, they can do it. But if I operate on somebody from Plymouth and put a band in them, where there's no gym, no sidewalks, it's just not going to work. And that's something that's unique to Eastern North Carolina. So it's you do see good results with the band, but they tend to be in metropolitan areas with pretty highly educated patients. And it really is just a belt that we buckle around the stomach. It has a balloon on the inside that's connected to a Metaport, just like chemotherapy. So if they come in with a band that's slipped or tight, you just get a Huber needle, just like you're accessing a Metaport, and you suck all the fluid out. So sleeve gastrectomy, this is, I think, going to replace probably about half the bands. I think half the bands that we're doing now will become sleeve gastrectomy. And what we do with that is we take a bougie tube, which is a big solid rubber tube, and we pass it down their mouth, and we staple along it and just narrow the stomach. It maintains the normal course of the alimentary tract. But surprisingly, this is just a restrictive operation, just like the band. Food goes through, gets absorbed normally. However, we see similar, not as good, but similar remission rates of diabetes with this operation and weight loss compared to the gastric bypass. So there's got to be some type of hormonal component in the stomach that's either creating better satiety or a signaling. It's also a theory that you're having a increased dump of food into the intestinal tract, which creates what's called like an ileal break. So you get food in here, it signals back to your head, don't eat anymore. But that's a big area of research, and we're getting ready to start looking into doing research with that too. But it's, as far as complications go, it's similar to the gastric bypass. And I'm going to go, you could still have a leak along the staple line or bleeding, but long term, you don't have to worry about malabsorption or stomach ulcers or anything like that. So I think this is going to be a good operation. Really good 5-year data is not quite out yet for this. So there's concern about pouch dilation or worsening of reflux if they have reflux. Because one thing the fundus does is it acts like a blow valve. So if you have a big gas bubble or a lot of food, it's going to go up this way instead of going up into the esophagus, and you've done away with that. So let's talk about complications, things you might see if you're go into the community and you're working in a hospital, in an emergency room, or somebody presents to your office with these kind of problems. So with gastric bypass, marginal ulcers are one of the biggest problems. Don't know why it is. It's the bane of my existence as a weight loss surgeon. I'm going to say this multiple times: no NSAIDs in gastric bypass patients. Internal hernias, we're doing quite a bit of rearranging of the intestinal tract and create some new pockets and holes where you can get a bowel obstruction pretty easily. So this is going to present like a good old-fashioned bowel obstruction. And gastric outlet obstruction or stricture, usually a result of a healing ulcer. They're going to present with early satiety, anorexia, wound infection, incisional hernia, malnutrition, and hypoglycemia. This is kind of a new area where Dr. Dar and I are having a lot of interest in lately, and really not quite sure on the incidence of this, but it's a very interesting problem because it tends to be in mostly non-diabetics. So ulcer disease, obviously cigarettes, NSAIDs can cause that in anybody without a gastric bypass, but there are some mechanical problems such as non-absorbable sutures or the type of staple anastomosis. So any of you going into gastroenterology, you're doing your GI rotation, you're going to see this. So you come in into the pouch, and just past the anastomosis where the intestines are connected to the new pouch, you're going to see a big ulcer like this. We don't know what causes it. We've tested pHs, all normal, H. pylori negative. We do know that if you have a gastric bypass and you're taking a bunch of Motrin or Advil or smoking, you have a good chance of doing it. Early ulcers are usually my fault. Made too much tension on the anastomosis, called some ischemia. And we used to use permanent sutures, and we found that there would be a suture with an ulcer around it. Pouch orientation, so we have to make sure we don't make it too longitudinal and catch some of the parietal cells. So you can have a bunch of continuously stimulated acid cells without any type of neutralization. And then a gastric fistula staple breakdown. I'm going to talk about that in a minute. How do they present? It's just a myriad of symptoms. Most commonly epigastric pain, left upper quadrant pain, same as you would have with a patient with a normal anatomy. Pancreatitis, the anastomosis sits right on the pancreas, so sometimes you'll just see inflammatory response kind of cause an elevation of amylase and lipase. Nausea or anorexia. A lot of times they'll come in saying, I just don't like eating meats anymore, so really solid foods will irritate them. Again, very similar to peptic ulcer disease. Or they may just have a positive Hemoccult test, or they cannot come in with free perforation. It's really only about 1 to 16%, but our residents, I think it's 85% because it's probably the majority of our readmissions for gastric bypass. So I think it appears to them as much more problematic than it actually is. So this is gastric fistula. So this is when you're scoping the patient, you'll see what looks like intestinal mucosa, and then you'll see this big hole here in an ulcer. And what's happening is the acid is refluxing out of the stomach, old stomach, and onto the intestines. And there's no bile or pancreatic juices to neutralize that acid, so it burns a hole right into the intestines. And why we see a lot of this at East Carolina is because of our long history. So it's all Dr. Pori's fault. So when they were first starting it out, they would fire a staple load, a partition staple load, so we have staplers that'll partition and staples that partition and then cut. Now we do a cut or divided, and that's because Pori's realized that one staple load, 75% of them opened up. He'd fire 2 partitioned, and 50% of them would open back up. The operation will just reverse itself. It's quite amazing that the anatomy, you can actually partition off with a surgical stapler and it will open back up. So oftentimes for a gunshot wound for the duodenum, we staple off the stomach right here and allow that to cool off, and after a month or 2 it'll open back up. So anyway, once we stopped doing the divided, the incidence of gastric fistula and marginal ulcers really shot down. So that was really one of the big things about the problems with weight loss surgery in the past, okay, was this. So I didn't want to bore you with a lot of surgical anatomy, but I think you need to know so that you can dispel the myths to your patients about the safety that, this was the Model T Ford, we're now up to the Mustang GTO, okay? So management of peptic ulcer disease, I'll get calls from outside hospitals, from hospitalists saying, I've got a patient here who's got an ulcer, they had a gastric bypass, what do you recommend doing? It's really pretty similar to what you do with normal peptic ulcer disease. I usually give them 30 days of a proton pump inhibitor. Prevacid Solutab is usually works a lot better for gastric bypass patients, just dissolves on their tongue, but a lot of times there's, as you know, the Medicare, Medicaid, Aetna, all have a different proton pump inhibitor or a H2 blocker that you can use. I can't keep them all straight. Carafate 4 times a day, and then I usually repeat an EGD in about 3 months because they can, as that ulcer is healing, it can scar down and cause a stricture. So if they come in and they're just not tolerating anything, they're dehydrated, usually I give a banana bag because go over this in a minute, but patients after gastric bypass need a lot of vitamin supplementation. If they've had a lot of problems eating, drinking, they probably haven't been taking their vitamins, so it's good to just hit them with that and lots of IV fluids, and they instantly feel better. And then we do a Nexium drip, and I know the health span automatically puts 4 milligrams an hour, but I find 8 really cuts the hospitalization in half. And as soon as they're not having any pain, I feed them and send them home. So lap band complications. A lot of bands out there. You can advertise a band. It's a product. You can sell it on TV. The lady that did the purple pill advertising for Nexium, the band company hired her. She got it written into one of the soap operas. So one of the characters in the soap operas had a band for a while. So there's a lot of bands out there, and you may see them present to the emergency department or in your clinic with problems. A lot of people will go down to Mexico. There's a holiday package. You can go down, get a band put in, and enjoy the Mexican Riviera. So we see a lot of patients with bands that were done elsewhere. Over tightening's usually pretty common, and the doctor that did it's going to hear about it within the next 24 hours. Slippage, erosion, wound infection, and this is just to show the difference between a lap band surgeon and a weight loss surgeon. If you can do a reflux procedure or pretty much any basic laparoscopic procedure, the 20-minute band bills about $3,000, and so there's a lot of push to do these. So in East North Carolina, most of the major hospitals have surgeons that place bands, but here at Vidant, it's the only place where you can get full service weight loss surgery. We see they talk about 40% diabetes improvement. However, if you look at Dixon's paper and JAMA, it was hand-selected patients that were on metformin alone. So that's a little different from Dr. Pori's paper in the 90s, where we took all comers diabetics and showed 85% remission. So if somebody comes in, they're not eating right, they have a band, you get a swallow test on them, it's going to look like this. You've got the band and esophagus, narrows columns, and then into the stomach. That's a normal swallow test. A slippage, you're going to see the band and you're going to see this big stomach up above it with particles of food and contrast in it, because when the stomach slides back up through it, it flips over and is kinked off, so it may come in with obstructive type symptoms. Easy enough to fix. You just get your Huber needle and you access the port, pull all the fluid out, and have them follow up with whoever put it in. Erosion, going into gastroenterology, you may see this. They'll come in with abdominal pain, fever, maybe not able to control their hunger anymore. You'll do a swallow test on them, and here's the band. Instead of the contrast going through it, you see it going around it. You scope them, and you retroflex the scope. Here's the scope, and you see this plastic thing in here. And if you're going into gastroenterology, this might be a really great future for you, is removing bands. You can actually go in and cut through this band, and you can pull it out through the stomach. Okay, you just get the surgeon, and as an outpatient, I can open up the wound, take out the port, disconnect it, and drop the tubing back in the stomach, and then with the endoscope you can go in, cut it, grab one end of it, and pull it out through the mouth. It's much easier said than done, though. So treatment of erosion, surgery or endoscopic removal. I'm going to move on and talk about safety of these operations. So National Surgical Quality Improvement Protocol program database, with 1,000 patients, the 30-day morbidity and mortality rate is now 4 and 0.2. Okay. To compare that to some of the more common major operations, the only thing that would come close would be a hip replacement. So craniotomies, cabbages, much more dangerous than weight loss surgery, and preventative would prevent a lot of these operations from happening. Okay. So I get this all the time. My friend had it and they gained all their weight back. So it's not a magic bullet. Our patients are required to see a nutritionist and a psychologist before they have surgery. A lot of times I'll refer them back if I see that they're having some issues and not really on board with it. It's an extensive workup. Somebody comes to see me with inguinal hernia. I'm in the room for 15, 20 minutes. I examine them, I operate on them 15, 20 minutes, see them back 15, 20 minutes, and we're done. Okay. Gastric bypass, weight loss surgery patients come to see me. I spend, they spend 30 minutes. Right now, I've got clinic at 9, and right now my patients are over there. They're in an information session for the next 40, 30 minutes. And we go over the anatomy, lifestyle changes, possible complications. I'll come and see them, have another 15, 20 minutes with them. I draw pictures, talk about lifestyle changes, I always present them with all the options: band, bypass, sleeve. And then they go through an extensive workup that's required by insurance: ultrasound, barium swallow, anesthesiology, psych, nutrition, EKG, labs. If they have, blood pressure, cholesterol, diabetes, they all go see cardiology. If they have dyspnea on exertion or asthma, they go see pulmonary to get a sleep test. If they have a lot of reflux or dysphagia, we'll get them to have an upper endoscopy. A lot of times I'll give them a goal weight. So you've got to have, lose 10 pounds. You got to have a negative nicotine test. We will not operate on them if they're smoking. and we test them. We don't trust them when we're upfront about that. You don't have to tell me if you quit. We're going to test you for nicotine. They come back for the decision visit, and once all this is completed, we go over it with them. We say, do you have any questions about the different options? And it's their decision. It's got to be their decision because they have to live with it. And once they've made up their mind, then we submit to their insurance company. When we hear back from the insurance company, we schedule their surgery. We then put them on a liquid diet. It's called OptiFast. It's a lot like Slim Fast. And the reason why we do that, I mean, it does cause weight loss, but there was a study performed a few years ago where they did an MRI on an obese patient, showed this massively fatty liver. They put them on a 2-week Slim Fast type diet, re-imaged them with MRI, and all the fat was gone from the liver. And that's important for me as a weight loss surgeon, is because the liver is big and thick. It has a real rounded edge, and normally a liver is nice and has a nice crisp edge on it. And to get the stomach out of the way to operate, get the liver out of the way to operate on the stomach is very challenging and used to result in conversion to an open operation. We would crack the liver occasionally, so it's really increased the morbidity rate. So a lot of times the patients think, well, we're just doing this to have them lose weight, but it's not. It's to help them get the procedure done laparoscopically. We do run into a lot of problems with patients being able to afford this. It's about $70 a week, and we try to do a little financial planning with them, try to show them that, okay, for the next 6 months, you're not going to be eating hardly anything at all. So the money you're going to save in the long term is going to be there. Also counsel them on the types of food choices they're making before surgery. I ask them, so what do you drink mostly? And they're like, oh, I drink Diet Mountain Dew. And it's amazing. You just stop diet drinks and patients will lose 10 pounds. So there's something in the diet drinks that makes them graze. I think it's like methadone for narcotics addicts. It never gets them off of their addiction. It's just a safer drug. And just tell them to go out and just do something, just exercise a little bit. And the studies show that those patients who gain weight before surgery are the ones that do this. And so I've stopped operating on them. So if a patient comes back to me at their decision visit and their weight's up more than 10 pounds, I tell them to come back and see me once they've lost it. So I think it's for the good of society. They've got to get on board with the plan. Otherwise, they're going to keep contributing to this myth here. And then the other thing is our fault as surgeons with the divided versus non-divided. So there are patients out there, and if they've come to your clinic and they've had the gastric bypass and they've regained their weight, send them to see me. Okay, we can revise this. We're very good at it because this is where most of them are. And we have a good experience with partitioning the stomach, dividing it, and redoing the bypass. And they don't get as much weight loss the second time around, but it does get them down to a healthier weight, and we do see some comorbidity resolution. And to put some numbers behind that, 16-year follow-up at ECU, average maintained 100 pounds excess weight loss. That's pretty impressive. When they started at a BMI of 51, now they're down to 37. Still overweight, but the difference in comorbidities between here and here is huge. And if you look at that NISQIP article, it talks about BMIs when you get 50 and higher, it goes up a little bit higher than 0.2. So it's everything gets more complicated, surgery, comorbidities. So good. Let's go back to the 1980s. This is Dr. Pori's first patient that when he noticed this weight loss does not occur first, but resolution of diabetes does. So we're just checking the glucose, insulin requirements post-operatively. Obviously a stress response, making them a little more insulin resistance, required some insulin immediately post-operative. And then as the days went on, glucose levels returned to normal, followed up in clinic about a week later, and no longer needed it. So average weight loss here is going to be about 10 pounds within the first week. And about 12 years later, we did a study looking at insulin levels, gastric bypass, between lean, obese, and diabetics before surgery and after surgery. So pre-surgery, we're seeing the green line here, the diabetics, they're hyperinsulinemic. Insulin levels are way high, and when you feed them, they don't really have much of a response. They just kind of get a little bit higher and just kind of plug along, where a non-diabetic or a lean patient, the blue line here, you feed them and their insulin levels appropriately go up and then taper off within 90 minutes. A week after surgery, we test the insulin levels in the same patients, and they have a robust response with insulin and then returning to normal. So the hyperinsulinemia goes away within 1 week after weight loss surgery. So how do you care for these patients when they come back to your clinic? What kind of things should you keep in mind? Generally, they should be on 2 multivitamins, B12, because the intrinsic factor, they're not getting a lot of that because the stomach's isolated, so they can run into some anemia problems. Vitamin D, that's everywhere in the journals now. It's just the general population should be on vitamin D. Calcium, and then menstruating women need to be on extra iron. And this can be very problematic because gastric bypass patients have a lot of problems with constipation. I don't know if that's because we're dividing some vagal nerve fibers when we come across the stomach, but you do see a little, I do have a lot of problems with constipated patients. Pregnancy, yes, and we usually wait about probably 18 months after gastric bypass before we tell them they can have a baby. At about 9 months, patients' hair can thin. It doesn't fall out, and I always tell them, you know, I can't feel sorry for you. My hair's not coming back. Yours will, and that's just a reflection of kind of the severe, rapid weight loss they're undergoing. When their hair starts coming back, that's when we see the weight plateau, and that's when I tell them you've got to really start exercising if you want to hit your goal weight. I don't have a goal weight for my patients. I have a list of medications that I want to see cut in half or eliminated altogether. And once that's achieved, which is usually about at 9 months, then I tell them I'm done. If they want to lose weight or look good in a bikini, then they got to see a cosmetic surgeon and a trainer. But if they're losing their hair, there's no way they can maintain a pregnancy. That's what I'm trying to say. So, but once their hair comes back at a year, that's when we can recommend some elective type procedures. They're going to heal better. So that's when I send them back to the orthopedic surgeon if they even need to get their hips done or knees done. But a lot of times they're so destroyed that they need to. But a lot of times I'm finding that they'll go to their OBGYN. OBGYN will see that they're on all this and go, you don't need prenatal because you're already on all this. This makes them a normal woman, okay? And a normal woman needs a prenatal vitamin. So you bring them up to the normal nutrition state, you get them pregnant, they need an additional prenatal vitamin, okay? So if you see somebody who's pregnant comes back to your clinic and they're not doing that in addition to that, make sure they do that. What can they eat? Generally want to see them eating about 3/4 a cup to a cup. They can go to any restaurant. We have little cards we give them that they can get a kid's meal, so they don't have to spend all the money. Restaurants hate that, but they can get a child's portion. If they eat sugar or fat, they don't have all the digestive enzymes that we do. When it comes out of your stomach, it gets neutralized. When it comes out of the pouch right into that intestinal tract, it's like an osmotic load, causes some osmotic type diarrhea type symptoms. They get crampy abdominal pain, maybe some explosive diarrhea. They're all like, oh, I don't want to have dumping. I tell them dumping's your mama slapping your hand when you're reaching for the cookie jar, okay? It's not going to put you in the hospital, but you'll think twice before you reach for that cookie jar again. So that's I think one of the biggest reasons why the bypass works better than the band is because a lot of the sweet tooths are cured by the gastric bypass. So always continue nutrition and exercise counseling. Again, it's not a magic bullet. Tell them that's why we have New Year's resolutions. You're gonna gain a little weight at 5 years, and you just got to realize that it's because you're not exercising. You made some poor food choices. You're hitting the breads and carbs again. So just get back on track. Everybody fluctuates, and what we want them to do is fluctuate at a healthy weight and not at a morbidly obese rate. You need to reevaluate their CPAP. Have they discontinued it on their own because the settings are too high or because they don't need it? We don't know. We need to reassess that. Do they need to be on their insulin, their lisinopril, reflux medications, Lipitor, et cetera? Are they experiencing abdominal pain, anorexia, hypoglycemia, or marital stress? The divorce rate's actually pretty high, gastric bypass patients. A lot of times, usually for patients who are morbidly obese before they get married. I don't know if it's because they're settling for less or they're putting up with a cruddy marriage to begin with, but then once they get this new lease on life through getting better health and become more active, but we do see that it can be a problem. Check looking for anemia, any white count being too low for signs of malnutrition, albumin, B12, vitamin D, calcium. If they're diabetic, we obviously follow hemoglobin A1C. Any unusual neurologic or skin problems, so they have any ataxias or nystagmus or visual problems. Those can be related to a micronutrient deficiency. And I would ask them, are you taking your post-bypass vitamins? Skin problems, you can see some zinc deficiency type skin blotchiness or scaliness, gum disease, that sort of thing. All could be reflections of a malnutrition. And they really should see their surgeon every year. I mean, weight loss surgeons are an odd group. We see our patients at 2 weeks after surgery, again 2 weeks later, at 2 months, and then every 3 months for the whole year. And then we want to see them back every year. We really want to be their, not medical home, but more their surgical home, and to make sure that everything's going well. I enjoy the long-term relationships with my patients, and it's a lot better than when I get calls at night from my partner's patients. Who did your surgery? I can't remember. But most people that I've done a weight loss surgery on, they know me and I know them. Although it is kind of hard because I'm not good with names. I'm better with faces, and my patients' faces change throughout the year. So they'll run into me and like, hey, Dr. Penner, like, hey, how you doing? And it's a good relationship. So what happens when they kind of come into into the hospital? So you can't do an ERCP, right? You can't get there from here anymore. This is 150 plus 60, 70, so it's longer than the ERP scope. So how about a nasogastric tube? Well, you could place a nasogastric tube, but the path of least resistance, the shortest way, is backing up this way, and so they're going to have a big dilated stomach. So nasogastric tube's not going to do too well to decompress any distal obstruction. You can place a nasojejunal feeding tube if you need to feed them, but you're not going to be able to do bolus foods through it because it just doesn't have that volume. It's going to be more like a nasojejunal feeding tube, continuous tube feeds. Can you peg them? No, because the liver's right here. It comes down to here. If they do need a feeding tube, you have to place a laparoscopic gastrostomy tube. You can go and place a tube into the old stomach. But you got to realize when you start tube feeds that this stomach hasn't seen any nutrition for maybe months or years. And so you really have to go slow, starting out with a half-strength solution and moving up. Otherwise, you're going to get a bad osmotic diarrhea. Again, watch out for NSAIDs. The ulcers will form right here. Oral steroids, same deal. And tobacco. And if somebody comes in with a bad asthma attack or a flare-up that needs some steroids, just make sure you put them on a proton pump inhibitor and watch them closely for signs and symptoms of ulcer disease. So how do you make referrals? Who qualifies? we will do anybody 18 years of age and older. There's no limit on age. We take every patient. I sit down at their initial intake visit. I make sure they're okay to undergo surgery. If they can tolerate having their gallbladder removed, they can tolerate a gastric bypass. BMIs of 40 don't require any comorbidities. BMIs of 35, just a lot more comorbidities accepted, but generally insurance companies, diabetes, obstructive sleep apnea, joint pain, hypertension, hyperlipidemia, GERD, stress incontinence. It's all about money, unfortunately, for the insurance company. All these things cost insurance companies a great deal of money. And I'll get to that in a minute. But Medicare and Medicaid doesn't pay for it. Well, that's wrong. It's partly right. We lost it last year, but we got it back on January 1. And how did we get it back? Well, Dr. Porres and several other physicians went to the governor, showed the increased cost of obesity compared to smoking, being 20 years old, over old age, drinking, much more expensive. It contributes to 300,000 deaths annually. We're performing about 200,000 of these a year. 51 billion, or 10% of healthcare costs, are directly related to obesity. North Carolina's 27% obese. There's a study, and there's been several studies since this one, but 78 patients aged 50 to 70, they took all their medications, added up the cost, performed a gastric bypass on them, and the cost savings annually for those 78 patients was $240,000. So monetarily it made sense to the governor, and she got it back for us. So if this is your patient, Lantus, metformin, CPAP, lisinopril, metoprolol, joint pain, Lipitor with BMI 35, you might want to think about referring them. How do you do that? We're all really good at what we do individually, and we're great doctors. We take great care of our patients, but it is really hard to work within the system. And stand up on the podium here, literally, but I've come to say, the referral network, just email me, okay, and I'll set it up for you, okay. Send me a flag and Logistin or HealthSpan to me. If you want to use the other systems, the weight loss, the website and the referral phone number, that's fine too. But most patients can do self-referrals, and to be honest with you, that's where most of the patients come from. They just come to see me because they want to have it done. The patient populations, as you know, are very well educated. They've got internet access. They figure it out. They don't want to live like they're living anymore, and they just come to see me. Carolina Access does need a referral from you, and TRICARE and some of the HMOs need a referral. But otherwise, they can just come over and see us. So, go back to the myths. It doesn't work. Hopefully, I've showed you that 50 to 80% excess weight loss, 85% improvement in diabetes mellitus. You can read the New England Journal of Medicine for that. Is it too dangerous? 0.2%. So that's the same thing as having your gallbladder removed. They'll just gain their weight back. Showed you the data, 16-year data, average 100 pounds still off excess weight loss at 16 years. Insurance doesn't cover it. It does. Patients are forced to eat a liquid diet, and that's why they lose weight. No, 6 months they're eating at restaurants around town just like you are. Fat people just need to exercise and eat right. Well, that's true to some point. And I want to talk about discrimination, okay? A lot of times, I showed this picture to my wife last night. She was like, "Why are you showing that?" And I said, "Well, does that make you happy or does that make you angry?" And she says, "Well, it makes me a little bit angry." And I asked her, I said, "Well, what happens if you go to the oncology floor and you see somebody, dying of lung cancer, somebody up in the cardiac unit suffering from a heart attack? Does it elicit that same kind of guttural response like, 'Oh, you brought this upon yourself'?" No, you have compassion. You feel sorry for them. You, as a physician, want to help them, help themselves, make them better. Thank y'all. And read these articles.